So we've started recording, so we're going to start over for the sake of recording something that makes sense. And so welcome to our research planning meeting of Florida Orthopedic Institute and private course to discuss cardio orthopedics. And so we are working on a case report which our fourth year fellow is working on. And she's just came online, Rachel Harris. Hello, Rachel. And Rachel's tuning in right now. And so let me go back here. And there's Rachel coming online. She is currently self-muted. And so she's our fourth year fellow starting in July. Hi, Rachel. How are you?
Good morning.
Good morning. So you've got a little echo. And so Rachel is going to be helping us on our projects. And so we've got the case report that she's going to work on. The patient we predicted was going to have a heart attack, which is a very remarkable case report. And then two, we're going to work on an abstract coming up for an international meeting on innovation in London that Dr. Gutsky is going to be presenting. And then three, there's a meeting of hip and knee that's coming up about the same time frame. That's going to be in Dallas, Texas. And so we want to get that abstract put together. And then we're going to continue to co-contribute to TJA, Cardio Orthopedics for Cardiologists and Orthopedists, which is the upcoming book that we want to write, either as an editor or an author. And everyone gets an opportunity to be part of all these projects. And then last of all, we have a monthly cardio orthopedic international meeting with Poland, which is the only other group that's involved in cardio orthopedics. And our Polish colleagues meet with us the first Thursday of the month at 9 o'clock. And they're going to be presenting their 200 cases of hypertension in patients who are having orthopedic surgery. And so we're really looking forward to that. So there's nobody else in the world involved in this project except our Polish group. And I'm delighted because I actually have an appointment as a deputy editor of a journal in Poland that's called something similar. It's Cardio Oncology, which is an organization that we started about 7 or 8 years ago. And so you can see that's the model for what we're doing now. So to continue on, everyone's probably somewhat acquainted with the Charlson Comorbidity Index, which is, unfortunately, it's not modifiable. You can't change your age or whether you have diabetes. For the most part, congestive heart failure exists as a historical event, and MI and peripheral arterial disease. And so it turns out that the Goldman criteria, the Canadian risk score, and the Charlson Comorbidity Index, all of them are cast in concrete as historical events. And so it's not modifiable. And so what we're working on is the Tampa Bay risk score, and we have a raw risk score, and then we can modify that and become attenuated risk score. So we have the only risk score in the world that you can modify and change the risk. And you can see there that we have what are called bundle busters in relationship to the bundling of orthopedics. And then we have something called with attenuated risk, which is bundle boosters. And so we've got our bundle boosters, which is the ability to modify something that exists, like blood pressure control, preventing atrial fibrillation, plaque risk. Probably we would call it, we have a dashboard that we use for modifying plaque risk. And so those are some of the things. So we'll just sort of move on here. And so just to get people interested, we start out now with a patient that we want to ask you what you think the risk is. And so here's a 79-year-old lady who's going to get right total hip arthroplasty. She has a history of pulmonary emboli after the left TKA. She has hypertension, and she's on 2 drugs for that. She got an EKG, shows first degree AV block, ejection fraction 70%. We do strain echo, which is one of our contributions to cardio-oncology, and it's extremely useful, and you'll find that nobody else uses this except cardio-oncologists right now, and then researchers in places like Australia, Hobart, Tasmania is the principal researcher on strain echo. And so we got allergy to adhesive zipline tape. We got, she's a very active lady until she got hip problem, and she has complex cardiovascular disease. And of course, you know, our model is Coronary CTA, which we have a 5,000 patient database called Sherlock program that we use for deciding what's going to happen to people in the future based on the past. And so this is a model showing this particular patient and the LAD lesion that she has, and the percent diameter is 79%, 89% cross-sectional area. The length is 5 millimeters. It has a lipid lake that's somewhat reticulated and disorganized. That's that red stuff on the transverse sections. And she has a convergent divergent double cone, which refers to computational fluid dynamics and the Navier-Stokes equations, as well as she has a 43% necrotic core involved in the stenosis, and a 35% necrotic core in the entire plaque. And so those are numbers that are useful on our Sherlock program in predicting cardiac events. And actually, nobody in the world uses numbers like this. Researchers came up with some numbers that didn't make a lot of sense, and they came up with what they were looking at was remodeling if it was positive, and if they had a fibrous cap that was very thin, which is very hard to measure on CT. And they were looking at, there was some lipid core, was their expression they used. And then there was something called a napkin ring. And just those 4 were researched and abandoned in trying to predict plaque as a predictor of cardiac events. And so then the story was that the leadership went on in cardiology to look for vulnerable patients that had plaque burdens rather than the Holy Grail, which was a specific finding of a plaque that you could predict when they were going to have a cardiac event. So the entire cardiovascular establishment and leadership abandoned looking for a vulnerable plaque, but we didn't get the memo down here in the provinces, and so we continued on. And so you can see that we have some lesions in different places here, which we're looking at, and this is a diagonal, and we're looking at the right coronary artery, and looking at, this is their first example you'll see of strain echo, which is entirely normal. And so this is our coronary artery dashboard that's based on what we call the Rosetta Stone, which I'll show you later. And this is that dashboard says we're going to have activated platelets, which we'll talk about later. We have a convergent divergent double cone. We have lipid lake, not well organized. And then we have a percent stenosis in a 79-year-old lady, which you see the decades of life at the bottom where the arrow originates. And but there's no plaque ulcer, and the plaque ulcer is our benchmark. You got to have one of those to be at risk, which is very interesting. No plaque ulcer. So you can look at the risk scores that I alluded to, which is Charleston, Goldman, Canadian, and then our own Tampa Bay risk score. And so what is the risk of this lady? And anybody make any comment? Rachel, you want to say something about what you think about risk in this lady?
I guess I was going to go back to the first slide. Would say that given her age, I think she has some intermediate risk features, but I wouldn't say that she's necessarily high risk.
Okay, and so basically I agree. And so she does not have what we call the characteristics of plaque that's going to be involved in a thrombosis. And so basically we called her low risk, and all we saw necessary to do was the Lovenox treatment for the pulmonary emboli that she had in the past and the DVT prevention and a nurse navigator. And the outcome was she did well. So the next patient we have is a patient who's going to get a left TKA, who's 77 years old, pretty equivalent, who has no hypertension, diabetes. She has a CAD-RAD score of 3, which means she has some coronary calcification that's a little greater than 50%, but no obstruction. Incidentally, she has left ventricular hypertrophy of 13, ejection fraction of 76%, and we made up our own score for carotids, and we call it a CAR-RADS, which is 2, which means less than 50% obstruction. And so the question is what her risk is. And so, Rachel, would you like to comment on that?
I would say she's low risk.
Yeah, so she seems like lower risk than the last one does when you look at what she's got and stuff. But the problem is, and we've learned this in our experience, is she has uncontrolled hypertension, which is earmarked by the fact she has left ventricular hypertrophy, even though she has no history of hypertension. If you got LVH, you have uncontrolled or unmanaged hypertension. If you have a history of hypertension and have LVH, in fact, you have hypertension that's been treated but not controlled. And so it probably needs 2 drugs instead of 1. And most of the patients we see are given a token 1 drug treatment for hypertension, and there's no real measurement of outcome. But it turns out that left ventricular hypertrophy is the hemoglobin A1C equivalent, as in diabetes, where you want to know the hemoglobin A1C and hypertension. You got to ask the question, do they have left ventricular hypertrophy? Because if they do, they haven't been adequately treated. So she had uncontrolled post-op hypertension and went in congestive heart failure and had to be managed. And so this was to show us, basically we got to treat their hypertension. We can detect it by LVH and we can manage it quite easily. And so this gives us the incentive to do that as we go forward in all our cases. And you'll find out how many people have uncontrolled hypertension that's been undiagnosed. You'll find that out shortly, and we'll show you. And so here's an interesting case, Rachel, of severe multivessel coronary artery disease and totally occluded right coronary artery with multivessel disease. And so, Rachel, would you like to make some speculation here? And I'm not picking on you. You're just the only person that doesn't know much about this right now, and we want to rope you into it. And you're a cardiac fellow, potential for next year as our 4th-year fellow, and we're looking forward to you coming here. And you're also an attending, and you're a cardiologist who's very, very good. So we did quiz a bunch of professors who are full professors and chairman of cardiac departments, and we asked them what they thought about cardio-orthopedics, and they said worthless. And we said, what do you think about predicting patients who are going to have cardiac events? And they said, we can't. It's totally random. And what do you think about patients that have cardiac events who have hip surgery? Save the heart, don't worry about the hip. And what do you think about saving the heart? We'll do everything we can. What do you think about the vents? Totally random, totally unpredictable. So it's really interesting that we're starting with that level of knowledge that just doesn't exist, and that's basically why. And so we're glad we got those answers from a group of full professors, because that's why we started to use the term cardio-orthopedics. You got to come up with something so people can understand that there's a little difference than what they believed. And that's what we want to do. So, Rachel, what do you think about this one?
So again, it's not an image that I can see perfusion in it. The degree of revascularization that's going to the right side, I would presume, based on the fact that there's severe disease in all major vessels, that this person would be high risk, but I'm not sure.
Okay, good. Thank you. That's what we want to hear. And so we'll pull this down. Hang on here. And we'll show you as we pull this down. Okay. Basically, and then we'll go back to where we were. Hang on. And the story is this patient did well. And so, and my story is that this patient did well because he doesn't have a plaque ulcer. And so let's go to the next one and talk some more. And we discussed this already. Oh, this is in particular to a patient that we're going to be presenting, and we're going to talk about what the risk was in this case by Chad's VASC and by our attenuated risk score and what it is by Charlson. And so, and this is our Rosetta Stone that we use, that we basically have taken 5,000 cases and condensed them to this one slide where we've got decades of life. We've got some little pictures here of what's going on inside the arteries. You start out with genes, lipid pool, inflammation, arterial wall, microbiota, macrophages, and you come into here forming a necrotic core. There's a chance you may have a plaque ulcer. You may get, as this changes, it will become fibrofatty and then fibrotic and then calcific. And then you may wind up with benign coronary calcinosis. Most people do. Or you can wind up with some malignant coronary obstruction with calcific stenosis. Or you can actually be over here in your 70s and be reaching back here and still have all kinds of plaque that's vulnerable and that's non-calcified. And so statins accelerate the calcification process, and then there's ways of reversing plaque with intensive therapy that we can talk about later. And so this is our program. Again, 14 years of coronary CT, 5,000 patients. We use we have the ability to get a CT scan and send the data set to Palo Alto, where with one keystroke, we can have in 5 hours the blood flow calculations from a supercomputer, giving us the flow down each artery and color coding that. So that's been particularly useful for us, and it's an innovation in cardiology. And then we are also associated with IBM Watson, but we haven't actually developed a program with them yet, and we've worked on several projects. We're the smallest company that's associated with IBM Watson, and our association is for cardiac imaging. And so these are the areas that we're involved in, which is special operations soldiers, first responders, police and fire, like the city of Tarpon Springs, for example, cardio-orthopedics, cardio-oncology. We're having our annual cardio-oncology meeting coming up here in September. Cardio concierge patients, which is the concierge practices. Cardio risk, people with multiple risk factors. Cardio CAD, people with chest pain or known coronary artery disease. So that's the group we've selected. And this is some of our team, of which there are many others, that work together with us in private cores for our research and technical analysis. And this is your group from Florida Orthopedic Institute, that we're glad to be associated with these fine people. And basically, everyone is familiar with the American Academy of Orthopedic Surgery. And basically, why are we involved in cardio orthopedics? Well, basically, silent heart attacks apparently occur a lot when you look at the literature of cardiology and orthopedics. There's a cost problem that's involved in the bundle equation, and then we think that the cost can be reduced by predictable and containable risk. Prediction, not narration, is the real test of our understanding of cardiology from the Black Swan, except we just threw in cardiology. And these are the things that we've done and the steps we've done with Penny and with others to bring this to fruition where we are now. And we have coming up the next fourth International Cardio Orthopedic webinar, which is going to be the first Thursday in May at 9 o'clock. And I hope everybody's invited, and we hope you can attend. It used to be that DVT and pulmonary emboli were number one, but orthopedists have done a great job containing that risk. And if you look at the AAOS, there are 183 pages of guidelines for preventing DVT and pulmonary emboli, which is interesting because we look now that cardiovascular is number one cause of serious complications from the literature. It turns out that there's one page for cardiovascular for knee guidelines from the AAOS and one page for hip from the AAOS. So they really haven't paid much attention to this. This
Eric,
is our own practice.
Eric, I got a question. Eric, I got
Yes.
a question on that.
Yes.
On that last slide. Could you go back? Yeah. Is that number one risk for all patients undergoing total hips and knees, or patients over the age of 65 that are in these programs?
I think because the risk is so skewed to the right, to the older people, that dominates all the statistics. And so whether you consider those over 65 or you consider all orthopedic patients, it still becomes the number one, because it's under 65 is like zero, but when you throw these numbers in, it skews it.
Okay.
So good question. Feel free to interrupt anytime if anybody has question or contribution. This is our looking at our database and querying it and looking back what happened to people. You will see a recurrence here of atrial fibrillation, atrial flutter, coronary artery disease, heart attack, stents that goes over and over. It keeps repeating itself in our patients. And so we said, well, the bundle busters appear to be atrial fibrillation, coronary artery disease, and something to do with hypertension and LVH, just looking back on our 5,000 patients. And I've been startled by what happens to some of our people. And you can see there's somebody who died, who was a great patient of ours and totally unpredictable for us, who bled to death post-op. We can see people have had complications that have been interrupted the course of their therapy. And so it's something of big concern for us because of this. And this is something got me roped in because of what's happening to our own patients. We looked in the literature and found the same sort of thing. They didn't mention hypertension and LVH, and we'll add that to the formula, but they did mention myocardial infarction. I like the way they said this. Based on the findings of this study, it appears there is no increased risk of in-hospital mortality and complications, except for myocardial infarction. It's very funny. And then atrial fibrillation. And so this is interesting. So the literature is supporting what we're saying. And then we looked at atrial fibrillation, prolonged hospitalization in a group of patients. And so that seems to be pretty important. We looked at some costs for different things, including DVT, pulmonary emboli, psychiatric consults, Charlson comorbidities, and so forth. Because of the bundling, it's important to know the cost. We looked again at congestive heart failure, valvular heart disease, coagulopathy, CHF again, myocardial infarction or cardiac arrest, looking at multiple studies. And this is the SHA study, which is from the Mayo Clinic. And they had a pretty big number for myocardial infarction and cardiac arrest. And this is another study about incidence of cardiac events within 90 days, stroke, cardiac arrhythmia, and so on and so forth. And then just looking at a compilation of 8 research studies that were systemically compiled together. Generally, myocardial infarction or heart failure were the leading causes of death, and also of complications. So that's kind of interesting. And we got lots of stats on that. What's the prevalence of cardiovascular disease in these age groups? And so over 60 in male is 69%, in females 68%, and then over 80, 84%. These are from the CDC. I don't know what these numbers mean because we're going to look at our own numbers and see what they have to say. I don't know prevalence of cardiovascular disease, what that word means. So hypertension over 60 looks like a similar number, just a little bit less. Couple of percentages left, but a similar number. And then this is about the troponin I measurements that are taken post-operatively on a group of patients, with 1 out of 7 having a highly sensitive troponin T Roche Cobus platform, 5th generation. And so we found this so intriguing that we're setting up our own Roche 5th generation Cobus platform at Memorial Hospital to start pre-testing patients. If this is sort of a keystone, then we want to know that, and we want to know what ours are. So we're going to look at that. And we got, the test is very expensive, $3.50, I think. Perioperative myocardial injury, 1 out of 7. And perioperative myocardial injury, 1 out of 7. Again, those over 65. Congestive heart failure, if you have a positive troponin, you can have congestive heart failure much later on. And so just a positive troponin has some meaning down the road. It's really important. And looking at the numbers, the predicted were like 20% coronary artery disease in 60 to 79-year-olds in terms of prevalence. And some of these numbers we got from Orthopaedics were from 20 to 27 to 32%, which was a lot higher. And so you say, is that because of osteoarthritis that's increasing the risk? Is it a sedentary lifestyle? And we find that when we talk to people, when they lead up to total joint arthroplasty, it seems like there's a 6-year gap before they get their surgery, by which time they've gained a lot of weight, they had a sedentary lifestyle. It's really amazing how long it takes to make that decision to get your knee done or your hip done. And then post-operatively, we'll talk about the activation of clotting factors and the greatly increased risk, but a declining risk of a heart attack over weeks. And then actually 1 year post having surgery, the risk is decreased over that of normal people who had a hip or knee, which is kind of interesting, less than normal. And so this is awareness of cost, and we don't know what the cost is, and so we stuck it up there. You know, what is the total cost of cardiac complications, myocardial infarctions, atrial fibrillation, and we're going to fill in that blank before we get finished with everything. And so 183 pages, 2 pages. These are the 2 pages, which really don't say anything. So we got to rewrite these guidelines is basically the direction we've got to move in. So if anybody's connected to this group, we're going to have to get their attention at some point because their guidelines fall way short. What's unique about TJA and what's unique, how do the patients contribute to more cardiovascular complications? This is my idea, and basically 30 years ago when I was doing a transesophageal echo on a patient that had an LAD lesion that was proximal and severe. The lady was having surgery on her hip at Memorial Hospital by Dr. Jack Baker, and I put a TreeEE probe in, and I said it will monitor the anterior wall and the septum in the apex, and if there's decreased function, I'll start a triadial drip with the idea that I would want to prevent a heart attack and prevent ischemia as a problem. And so while I was doing that, all of a sudden there's this snowball effect of like a snow flurry. It's like a snow globe when you shake it up. And all we saw was this whiteout of the right atrium and right ventricle, which was kind of incredible. I'd never seen that before. And the surgeon was looking at it, and he said, "Turn that damn thing off, Harrison. I can't stand to look at that." Of course, he thought it was all fatty emboli, and he thought we were in a lot of trouble. And he thought this was an exception, but actually it's a rule. And actually what it is bone powder. It's not glue. It's bone powder. And here's a picture of it in the lung with some fat as well. And there's 2 little pieces of bone. And if you do a microscopic examination, there's fibrin attached to it. And so it turns out that this activates platelets like nobody's business and causes platelet aggravation and basically actually produce a hypercoagulable state. And you can measure the beta thromboglobulin and find that that's twice normal. And so that's very interesting. And I believe this is the common denominator, at least half the common denominator of why people have strokes and why people have heart attacks is from platelet activation plus. And we're going to talk about what the plus is. And so let's go on and skip the aspirin theory, which is very good. And there's Joe Lar, who was one of our patients who got atrial flutter post-op and had some anticoagulation problems and finally got converted. And we're talking about what the options are if someone develops atrial fibrillation post-operatively. But I think the best thing is to contain it or to recognize it if it's chronic. And so atrial fibrillation does have a risk of emboli, and we want to take that out as a problem. It produces more hypercoagulability as well, and so that needs to be recognized. So atrial fibrillation is easy for us to prevent. And then we're going to show you our index case, and Rachel is actually working to write up this case for us, and we want our orthopedist to be co-author with us, and we like to place it in an orthopedic journal. And so this is a gentleman who's 68 years old who has a remote history of atrial fibrillation 12 years ago.
Is this Watson's case? Is this Watson's case?
Yes. Okay. So this is a guy basically who was scheduled for Dr. Tom Bernasek to do the surgery, and he was sent to me because of the atrial fibrillation from the base. And so I saw him from McDill, and we said, oh, he's having atrial fibrillation. It's recurrent. They canceled his EGD, and I said, we got to suppress that perioperatively because he's going to be at risk of having problems like Joe Lar did back here, and so we don't want to do that. So we said, let's suppress his atrial fibrillation. But while we're at it, why don't we look and see if he has any coronary artery disease? And of course, that's what we do. And so here we are. There's a score that we're working on. It has a score of the Charlson Comorbidity Index of 2. And he's got a score by us of 11. And we can probably reduce that to 7 by taking out the atrial flutter. And so let's skip this story about the Canadian, and let's skip the Goldman criteria, both of which are non-modifiable. And let's look at, we have a recording device that gives us the ability to detect atrial fibrillation much easier than ever before, because it's like a little Band-Aid you put on people and you get a whole week of recording or 2 weeks of recording. And then we did the coronary CTA, and we call that pre-symptomatic complex plaque analysis. And so pre-symptomatic. And so this is the plaque that we found in this gentleman in his left anterior descending, which was in the 75th% phase. It's very proximal. It's very complicated. There's some calcium there. There's a convergent divergent double cone. You can see the narrowing, 65% diameter. Length is 9.4 millimeters. We're looking at the necrotic core, which is only 14.3% at the plaque, and only 27% of the entire plaque, and at the stenosis is only 14%. So this, by our standards, in terms of managing people who are walkie-talkies, is not a high-risk plaque, except, okay, and we'll show you the exception. An exception is he has a plaque ulcer, and the plaque ulcer, as you see there, is this thing that I'm directing little platelets to, and I'll see if I can get a laser pointer to be able to show you the plaque ulcer. So here's my laser pointer, and now we're coming over here, and here's the plaque ulcer. And so that can be seen down here as 1.2 millimeters deep and 1.8 millimeters wide. And so here's the convergent divergent double cone and the complexity of the plaque from the Navier-Stokes equations. Here's another plaque in the posterior descending. Here's the myocardium at risk. You can see this is a big hunk of muscle. Here's another picture of this plaque and its complexity. So it turns out this is a very complex plaque. There's a lot of muscle involved. We can actually measure the poor man's FFR, which tells us blood flow down the coronaries based on the amount of myocardium that's at risk. And measuring on the CT scan the amount of iodine that's in the myocardium distal to the plaque, we find that there's decreased iodine distal to the LAD as well as distal to the posterior descending. And it turns out that this is something nobody else in the world knows, and so I'm sharing it with you, Rachel, because we'll do probably a write-up about this. But this is that the CT MPI correlates with the strain echo, and it just turns out that people who do strain echo never see CT MPIs, and people who do CT MPIs, myocardial perfusion imaging, never see the strain echoes. So basically, looking at them, superimposing them, they're very, very similar in terms of, you have to actually rotate to match them because they have different polar maps. They're not exactly the same. And so here's our plaque ulcer again. Here's our convergent divergent double cone. And what we're saying, our hypothesis is that platelet activation plus complex ulcerated plaque, or atrial fibrillation as well, leads to CVA, or acute coronary insufficiency. So here's platelets that we got that are activated. Here's our plaque ulcer in the coronary. Here's a plaque ulcer in the carotid. And we think these are the risk factors that are combined with the bone powder activating the platelets. So that's why we're focused on knee and hip, because of the release of bone powder. And so there it is again. We think it's important to see that. Here this is for our students where we do a match and we take platelet ulcers that are well formed as opposed to not so well formed or amorphous and match them up with shapes and sizes and then predict which one matches with how long it took to get a cardiac event, which instantaneous cardiac event, 12 days to cardiac event, and 188 days and 420 days, trying to show some correlation, and here's where we match them up, some correlation with plaque ulcers. And there's a plaque ulcer to show you what it looks like with an IVUS. And the next question is, why didn't we put a stent in this gentleman? And so, one, he's asymptomatic, so he's not going to get a stent. Two, the guidelines basically don't emphasize putting stents in patients before hip and knee surgery. They consider the surgery intermediate in terms of risk. And you can see, if you look at the American guidelines or you look at the European guidelines as we go through here, basically it's not routine prophylaxis for myocardial revascularization before low or intermediate risk surgery in patients with proven heart disease, and so it's not recommended. And so that's interesting because we have patients that we're evaluating for you that have already had plaques that have been analyzed by cardiac cath and already had stents put in by doctors that were basically looking for patients to put stents in, and then they had their hip or knee delayed by 6 months because they had to be on dual antiplatelet anticoagulation prior to the surgery. And that was done well meaningful to basically try to contain the risk, which is doubtful that that's what they're doing. And so again, the Rosetta Stone that guides us. And now we've got the Coronary Ct Dashboard that we're showing on this gentleman that shows activated platelets and plaque ulcer and convergent divergent double cone and a little lipid lake, but not much, and a significant stenosis. And so we're predicting he is high risk. And so with that in mind, I called Tom Bernasek and said that we're going to move the patient off of his schedule and bring the patient to Memorial, where his associate, Dr. Watson, would do the case, and we get Sharon Barnett, our navigator, to navigate this case and one, prevent atrial fibrillation, and two, we're predicting a heart attack, and we want to be able to follow him and rescue him, and we didn't want him to get lost at Tampa General in the shuffle. And so that was our plan. And again, we couldn't stent him, and we told the patient, this is what we're going to do, and he agreed with it, and we said, don't worry about it, we will rescue you, because it'll be very timely, and we'll be tuned in to you. And so we told him what to recognize. We got a nurse navigator, and she's going to take care of him. And basically, Sharon did follow him in the hospital. He did quite well. His daughter came to pick him up at discharge, and she took him home. Sharon gave a cell phone number to the daughter and to the patient. Patient got home. Daughter dropped him off. He's having lunch, and he starts getting chest pain. And he calls his daughter, says, come back, I'm getting the chest pain Dr. Harrison said I was going to get. And they call Sharon and say he's getting the chest pain that we predicted. And then he comes over to the hospital. He's having a non-STEMI, and this results in basically evaluating him and finding some hypokinesis and some positive troponin, and then taking him to Tampa General. And here's his coronary artery seen on CT. Here it is again on CT. And then here's the lesion that's seen during the cardiac cath, which has been pointed out, and I don't have it on this slide, but we'll look it up and get another slide. It's been pointed out by the cathing physician who was unaware of all of this that we were doing, that the patient has a plaque ulcer there he is seeing on the cardiac cath. And then it's real fuzzy in there because of platelets and thrombus. And so he's rescuing him with a stent. And then you can see how clear everything is with the stent. And that he did well. Turia. Hang on just a second. Hello, Turia.
Oh, good morning, Dr. Harrison.
How are you?
Good. I have one of Dr. Glissan's patient on the table, but he was pre-medicated with Coronary, but the heart rate still on the 100. His heart rate right now is 103.
Oh, that's very unusual, so we'll have to cancel him, send him over here, and we'll figure out what we need to do. Okay?
Okay.
All right, thank you.
That's what we'll do.
Bye-bye.
Thank you. Bye.
So that was our tech on CT. We have to manage the patients very carefully before their CT to make sure their heart rate's okay. And so this is showing that there's no damage to his heart, which is by cardiac MRI, no damage. And so he was rescued without damage and normal contractility, and his hip was okay. And so basically this is our patient saying, I'm very happy that I had my hip surgery, and also grateful that Dr. Harrison and Sharon prevented me from getting atrial fibrillation, but also knew that I would get a heart attack, which they anticipated prevented damage to my heart and to my hip. And so the total cost was $28,000, and the cost of another gentleman who was kind of equivalent, who had a surprise heart attack in the hospital, was $40,000, and the cost of people who go home and have a surprise heart attack with congestive heart failure is $60,000. So there's a lot of difference. We were able to do this for just an additional $10,000, actually $8,000, which was not bad. And so these are some of the numbers that we discussed. And the other thing go ahead.
Sorry.
Yes.
What would be okay, so obviously we did this patient. I know this patient.
Yes.
What would be your recommendation, because we're talking about bundle, if you're that confident that a patient is going to have a post-surgical event, it's going to obviously cause a readmission, cause stenting, whatever the case may be. You're saying you can't stent in advance of the surgery because the indication is not there. What do we do in a situation like that where you are so confident and we don't really want the bundle to be busted? In other words, yes, he was much less of an expense than the average person, but obviously that's still over our bundle amount. Would we just go on word and say, let's wait for 6 months and see if anything happens before we do surgery and allow that stent to take place prior to doing surgery, or we really need to do it this way?
Yeah, I would think that what we'll do is actually, at some point, we will start stenting them.
Okay.
And so if we know that one, it's going to be upper knee, which we know activates platelets, and if we have a nice ulcer that's well defined and convergent divergent double cone and a significant stenosis, we're going to take all that together and we're going to wind up doing a bare metal stent so that then we can take him to surgery a month later.
Okay.
And so that's what we're going to do. And eventually, probably you'll be doing synergy stents, which have never thrombosed. And so,
Eric,
yes,
I got a question.
Yes, sir.
So are the insurance companies?
Hello? We missed part of your question. You dropped out.
Paying for a stent under those circumstances? Is that considered? No. Can you hear me?
Yeah, I can hear you. And could you, I think your question is, can we get the insurance companies to pay for this? And the answer is yes, because if I can show what I showed in this gentleman after my experience, that I've talked to my colleagues who are interventionalists, and they think we can get this paid for. Okay?
Okay. Yeah.
But we've got it, we can do it. And so right now, and I'll show you as we go on, there are patients who get stented who don't need stents, and then the patients who do need stents don't get stented. And so it's been that way for years. 50% of people who have stents don't need them right now. And so what they recommend you doing is assess the blood flow with the FFR, which we can do with one keystroke of our computer, because we send them to Palo Alto to a supercomputer and get the data back in 5 hours. So we can tell you what the FFR is as well. So we can come up with enough information to get these patients stented. And you have to realize also that atrial fibrillation is a co-contributor, because atrial fibrillation also activates platelets in a severe way. And so the combination of the two is not a good idea. We also want to make a point that evaluating patients preoperatively prior to bundling basically decreases the cost of a cardiac encounter in the hospital, because the average cardiologist touching a patient costs $7,000 to the system. So the medical system, it's $7,000 if a cardiologist comes. And so our evaluation has already been done preoperatively. So a cardiologist comes, which we had a case recently, and the cardiologist, there's nothing for them to do. There's no reason to do an echocardiogram. It's already been done. There's no reason to do a nuclear stress test. We've got the coronary anatomy. And so we cut the cost drastically if for some reason the patient has something and someone calls a cardiologist. We've already totally cut their cost, and that's why we want this data to be on the chart on each patient, the data that we've acquired, so it's obvious that we have done the workup prior to the bundling and it doesn't have to be done again. So it's very, very important, the amount of money that we will save if somebody happens to call a cardiologist. The other thing is that in our assessment of the patient, as the bottom line, we make recommendations on the assessment of patients, and the recommendations can be followed by the PA or by the ARNP. They don't need a cardiologist to follow our recommendations. And so that's another way of avoiding that cost. It's all designed for the PA to be able to accomplish what we recommended. And it looks like in 50% of patients, we're doing something different and making a change in their care prior to them going to surgery. And we'll show you that.
I got another question.
Yes,
so
sir.
Penny, it's for Penny. Under the current program, if a patient has their own cardiologist, they're getting the cardiologist desired workup, and Dr. Harrison is not seeing those patients. So that the cost of that workup isn't part of the bundle. Whereas if a patient is not been seen by a cardiologist, we then automatically send them to Dr. Harrison, and then there's a cost involved once they're into the screening program. Is that indeed how the program is currently working?
Not exactly, Dr. Gusky. So what we are trying to do is, even if patients have a cardiologist prior to surgery, they're still being recommended to do the testing through Dr. Harrison. They, obviously we're not requiring it. Many of them don't want to change cardiology, or not even change, don't want to go to another cardiologist. So we're not forcing that issue. But Dr. Harrison is kind enough to schedule all of our patients prior to the bundling period. So he schedules all of our patients for all of the complete testing prior to that 72-hour window, so it does not fall into the bundle at all.
Okay.
Does that answer your question?
So what percentage of patients are actually being seen by him, by Dr. Harrison, and a cardiologist as well?
That we'd have to look up. We
Okay.
did that yesterday, Susie, right? Susie and I can review that data, Dr. Gusky.
Okay, because that's what I was most interested in, is how effective this program is in terms of being better than the primary care alone evaluation, or the primary care plus the personal cardiologist evaluation, and decreasing the events and costs.
I think so. Let me just make sure what I'm understanding, or part of what I'm understanding. A way to do that then is, of those patients that had cardiac events prior to us beginning this program with Dr. Harrison, we need to determine first if they had their own cardiologist and had their own cardiologist workup to determine that, correct?
Correct.
Okay.
So we can compare that cohort
right
to the new group that has undergone the potential for screening, and then of the new group that has undergone screening, some of those patients in the new group will not have had screening. They will still have had their own cardiologist do the evaluation, so we can compare the effectiveness in instituting this new screening program compared to the old way with no screening.
Correct.
Versus the cohort that have had the opportunity to have a screening versus those in the new cohort who haven't taken advantage of that.
Okay.
That's what I'm most interested in.
Yeah, what it looks like is, in general, Dr. Harrison, out of the bundle patients that we had, only saw 35% of our patients. And of the 12 that had a cardiac event afterwards, Dr. Harrison, they were not seen by Dr. Harrison, and only only 7 of them, 7 of the 12 had a cardiac workup. The other ones were only seen by their medical doctor.
Yeah, that to me is the data and the significance of this program with that. I think, all this other way that it's done in terms of the testing is also fantastic, but the appeal to the orthopedic surgeon is the fact that they can institute a different type of screening program to decrease events and costs.
Exactly. And so there's a couple other things there. The cardiologist frequently doesn't really do much in terms of evaluation. They might do an EKG. They've done annual tests that are revenue generating as part of commercial cardiology. So what you're seeing here is called clinical academic cardiology, as opposed to commercial cardiology or institutional cardiology. And so with commercial cardiology, you sell them a six-pack every year. And it has nothing to do with whether they're going to surgery or not going to surgery. It has to do with revenue production. And the six-pack is basically a history and physical, an EKG, an echo, and nuclear stress test. And basically, if they find something on the nuclear stress test, then they do a cardiac cath and then if they find something there, then they do angioplasty and stenting. And it's all pretty well structured. Now, the tests they're doing cost a lot of money, but it generates a lot of revenue. So the nuclear stress test, stress echo, would have you, basically if you do 12 or to 14 nuclear stress tests a day, you make $4,000 net. So it's a financial enterprise under commercial cardiology. Blue Cross Blue Shield in Michigan did a study of 47 centers in Michigan that are doing stress nuclear tests, stress echoes, and stress tests, and found that of 100 people who don't have heart disease, 40 of them have positive tests and go on to cardiac catheterization. Of 100 people who do have heart disease, 65 are missed and go on with a reassurance that they're doing fine. Okay? So basically, it's a financial endeavor. It has nothing to do with adequate detection of heart disease. And so we abandoned that in 2004 because the model was totally flawed. And so have other people that are cognitive about this. Emory University Midtown Cardiology abandoned that and said, well, that's commercial cardiology, but it doesn't work and it's stupid. However, at Memorial Hospital, there's a 50% false positive, 50% false negative, so it's the same as the flip of a coin, and all cardiologists will admit that. And then at University of South Florida, there's an 80% false positive, and I called the chief of cardiology and said, how can you do this? I can help you learn how to do tests that are more effective and give better results. And he said, no problem. The dean's very happy. We're making lots of money. So I just need to let you know that the tests are worthless that are being done currently, and that's why we changed our total approach in 2004 and abandoned that procedure.
But out of
But I think you understand there's politics here, Eric, and there's the town cardiologists who don't necessarily appreciate us sending the patients to you rather than to them for whatever reason, whether it's monetary or just whatever. But if we come up with this data that shows that this kind of testing is better than what they're tending to do, then there's no longer any politics.
So have you had pushback from cardiologists? Because we made it a point to keep an arm's distance. We basically organized it under private cores, not Harrison Cardiovascular, and we've done everything we could to try to not retain the patient and to get them back to their cardiologist.
Yes, I have gotten pushback. I've had 2 cardiologists ask me about what's going on with this program. Why are we sending our patients to a different cardiologist when they are their the patient's cardiologist?
I got you.
So I think part of it is the patient doesn't necessarily understand why they're doing this. That may be the primary reason, that we're not communicating with the patients well enough, but there is some pushback. I think from the data that we're starting to see, all of our patients should undergo this screening. There shouldn't be 35% that we're sending through this. It should be 100%. And the only way we can get 100% is to prove that the 65% that aren't going through this screening are having more events and costing us more money in the bundled program than the 35% who are going through this program.
Yeah, we have a patient data set on slides that we actually show each patient when they come here, and we try to reinforce what we're doing, why we're doing. And the way we handle it is we say, your cardiologist is an excellent doctor and has done a great job and has prepared you for normal events in the course of your life to keep you from having a heart attack. But the problem is that having a hip or a knee is an extraordinary event that stirs up a lot of platelets that become activated, and the risk of that is higher than the experience of normal life of shoveling snow or cutting grass. And so we want to actually look at that and prevent that as a once in a lifetime event.
I think just so we're all on the same page, from my understanding of what Dr. Gusky's saying, I don't think he's saying that the issue is on your end as to when you're seeing the patient. Yeah. It's prior to them getting to you. It's in the way that we are approaching it on our end, explaining it or lack thereof to the patient. We need to get better on our end, or we need to have some type of standard, something written, whatever the case may be, so that we can explain it well to these patients. We're not taking you away from your cardiologist. We don't want you to stop seeing your cardiologist. This is a one-time shot. He's saying we need to get better on our end, not on your end. It's before the patient ever gets to you.
Right. And we certainly, when a patient does come and they say, I've had this and I've had this and I had this, I don't want further testing, we respect that. And we don't in any way push them into doing something that, and if they actually have, and sometimes they do, they have a false sense of reality and reassurance of the testing they've had. If you go get a nuclear stress test every year, it's a lot of trouble. You're getting 22 millisieverts of radiation. It's time, half a day. And so we don't want the patient to think that their doctors are scamming them. And so we try to reinforce, they've done a great job on you and blah, blah, blah. But this is an extraordinary circumstance. Although they are scamming them, by the way. So let's move on. And those are very, very good points. Thank you so much for sharing that with me. Those are great points.
Dr. Harrison, I'm going to need to run here in a few minutes.
Yeah, we've all probably got to go because we want you to be up to speed. And so, but to make it very quickly and end this, we're going to tell you this is before the bundling, what's happening. And it's basically a coronary CTA, which is basically paid for by Medicare. But if it was paid out of pocket, it would be a $299 test, which we've done great effort to make that possible by taking off of the plate of the technologist 45 minutes of post-processing reconstruction and doing that ourselves in our own lab over here. So we negotiated that price through the CFO by taking 45 minutes off the technologist's time and doing the post-processing over here on our own computers. And then the echocardiogram, which most doctors have and most hospitals, the echocardiogram at Memorial is 9-year-old equipment. So you get paid the same by Medicare, whether you got new equipment or old equipment. So we went out and got the best you can buy from GE, shipped in from Norway, and it took us 4 years to master strain echo and 3D imaging. And so the experience they're getting off the echo is unbelievable compared with what they get in town. Now, this isn't a diversity between town and gown because I'm sure there are gowns that are not very good either. So let's move on beyond that. And so this is after this is before bundling. Everything is before bundling. And we're looking for atrial fibrillation as one of our targets, and we'll talk about atrial fibrillation sometime in the future. And we're looking at cost, and basically, let's move on into what our cost is about $943. We haven't added the NT-proBNP yet, and we haven't added the highly sensitive troponin I, which is an additional $18. But this is what we're doing and what the cost is, which is reasonable, I believe. We actually try to do this in one day, hopefully a half a day. We try to get all this done at one time so they don't have to come back, because if they're from Brooksville or Riverview or somebody, we don't want them to have to come back. And we actually tell them, which is true, that they bring their disc back and we review the CT with the patient or his wife if they're together, and we show them what this means in terms of their long-term risk, which is extremely helpful because we're not just giving them information for next week when they get their hip or knee done. We're giving them information that's going to take them, out beyond another 5 or 10 years that they've never had before in terms of what their heart is like. So it's pretty cool. And of course, everybody I know has had the test, and every doctor I know has had the test, and I've had the test 3 times, and my wife has a test, and my wife has a 15-year warranty on her test because it was entirely normal. And of course, I gave her a price break. And so this is the assessment, which we want to have more involvement with the anesthesiologist, because this is the assessment that we write up on every patient in detail, and it looks like an anesthesiology pre-op sheet because it's so useful. And some places it's on the chart, some places it's not. If we can get it on the chart and get it to anesthesia, it's extremely useful. And somehow we have to liaison with the anesthesiologist that they see this information. Here's another way of constructing the same information, either horizontal or vertical. But it's great information. We're using this risk score. We'll have some more information on that. There's our patient that was our index case. Here's where Tampa people usually are. Indianapolis people are more like this that I see because we do off-site reading that's pushed to us from Indianapolis on a frequent basis, where we read for doctors that are having their studies read by radiologists and then send it for us for this plaque management. This is normal. So these are places you want to be. These are places you don't want to be.
Do you send that pre-op sheet to the doctor's secretaries that are referred over?
Yes, I do.
So that should go then, or if it doesn't, we can include it in our.
That would be wonderful.
Yeah, in
It should go to
all of our surgical.
Yeah. And also give a copy to the patient for the patient to keep, but another copy to the patient to give the anesthesiologist when they make their visit. So I'm trying to cover it across the board. Okay. And so these things, again, showing how patient-specific testing basically avoids cardiology consult because of all the stuff that's been figured out. And so that's pretty good. And so then let's go to our actual data. Okay, and this is CTO. Here's our actual data. This is pretty cool. We color-coded the data, and Rhonda likes this. We color-coded the data so that you can look from across the room, and you can see on the cases that we've done, green means not much coronary artery disease, and you got the green light from coronary artery disease. Red means atrial fibrillation, atrial flutter, sailor be warned, red skies. And the hypertension is coded with this kind of a purple color, and then maybe a magenta type color is the LVH. And then we throw something in like bundle branch block or blah, blah, blah is thrown in here, or if the patient declines a test. If you don't see a green, they decline the test. Show you some of this. So look, you can look through here. Now yellow means we did something that was an intervention that actually promoted the patient's care and was very important in moving them on down the line. So this gives you an idea, and then we have a gray, you'll see, where we found aneurysms that nobody knew exist, aortic aneurysms. And so we're actually saving lives long term on this group of patients. So if you see that we have, for example, hypertension with LVH, that means these patients haven't been well managed in their hypertension, because the LVH should go away if your case is well managed for high blood pressure. So you can see there's a lot of people that haven't been well managed, that somebody just put them on one pill and said that takes care of your hypertension. See ya. Okay, which is kind of interesting. And then you'll see some patients where they have LVH, but there's no hypertension. That means they have undiagnosed hypertension. And so here's LVH, no hypertension, LVH, no hypertension. So these are newly diagnosed hypertension that we've learned you got to put them on medicine. You can't just do that and let them go to surgery because they're going to have a problem. And so that's a new lesson for us. You can see a lot of people have bundle branch blocks, right bundle, left anterior hemiblock, all that stuff, which means nothing. Look at all the green lights. Everybody's green light. If coronary artery disease is such a bad actor in patients who are getting their hips and knees, how come nobody's got severe coronary artery disease? You can see all the normals, all the green lights. You can see people, if they have a stent that's open, we put a green light. If they have patent grafts, we put a green light. Look at all the green lights. Oh, pretty amazing. Let's go over here. Look at all the green lights again. Now, the pink means there's some ischemia, but if there's not a plaque ulcer, we don't care. So this is really interesting because everyone would grab this patient who's ischemic and go running away with them, and we say, we don't care about that. And so, because they don't have a plaque ulcer. And so this is interesting. And so let's go back over here one more time, and we'll show you someone else. This is an interesting guy because here's a guy that the cardiologist, a primary care saw an abnormal EKG, thought it was an old infarct. It turned out to be a false positive EKG. Then the patient got an echo and everything was fine. Then the patient got a nuclear scan and had a false positive nuclear scan, and then wound up having some coronary artery disease, and they went in and stented all the vessels except the one that was causing ischemia, because that was a chronic total occlusion, and that wasn't easy to cherry pick. So they took the low-hanging fruit and left the ischemia there, but we didn't care about the ischemia even, and sent him to surgery because there's no plaque ulcer. Isn't that interesting? So this is our little collection of people, and actually did you count the number of cases I sent you? How many we have now?
Oh, yeah, actually we did. It's like 90-something.
So we got 90-something patients, and we've got 77 that have been basically tabulated so far, and we'll be adding some more we want to get to 100 and look at those numbers. They're easy to work with 100 in terms of percentages. And so here's our 77 cases in tabulating. So for hypertension, undiagnosed hypertension inferred by LVH, we have 62% are hypertensive, which actually matches the prevalence of hypertension beyond the age of 60 is 62%, in males. And so isn't that interesting? We have LVH, which means hypertension that's not been well managed, in 40% of the patients have LVH. We have in the hypertensive patients, 58% have LVH in the hypertensive patients, which shows you that, let's call it 60%. 60% haven't had good blood pressure management. That's no surprise, but we want to contain that when they go to surgery. 14% had paroxysmal atrial fibrillation. 9% had chronic atrial fibrillation. This was kind of amazing to our Polish friends that there's 23% with atrial fibrillation. That's a big number, and atrial fibrillation, as you know, unfavorably influences the clotting process. And so that's a good thing to know. And then in terms of coronary artery disease that was insignificant or had patent bypasses or had patent stents, we've got 96% did not have significant coronary artery disease. They don't have severe lesions classified as over 70%. Isn't that interesting? After we have all this information from all these people, from all this stuff, from Mayo Clinic and everywhere else, that everybody's got a coronary artery disease, what a terrible problem. They're having hips and knees, and 1 out of 7 is going to have a positive troponin, and nobody's got coronary artery disease. Isn't that interesting? They have hypertension and LVH and paroxysmal atrial fibrillation. So we're rewriting the information that's available in the world today by doing this study. And then 52% had action taken, 4% had ischemia, and then we got 4% who have newly discovered, hang on, cardiology. Oh, some stupid ad. So we actually have 4% that we found aneurysms, which is life-saving. We found aortic aneurysms, and they didn't know about them. Some of them were pretty young. And so we're going to basically contact with the primary care doctors to give them this information so they can continue to manage their patients appropriately. And certainly
4% of our patients?
Yes.
Really?
4% of our patients had undetected aortic aneurysms. Isn't that cool?
Yeah.
And we got into that because it was interesting. We have a patient who was getting her hip, and she said, my dad died when he had his hip. And I said, what happened to him? He blew his aneurysm after surgery. And so that's, again, untreated hypertension, left ventricular hypertrophy. And how do you get there? you get an aneurysm, and that causes death. So isn't that interesting? Don't you think that's interesting, Ken?
Yes.
So we would take these numbers and this information, expand it to the 90 cases, and put that in your abstract of what are these patients like. And this is earth-shaking in terms of, this is what the real problem is. And take a look at this. This is our coronary plaque dashboard, and we have 56 patients who've had the coronary CTA, and we're looking on the dashboard. Here's 18 patients that are totally normal, 32 patients that have a low score, okay?
Dr. Gusky, I'm leaving. I have a 10:30.
5 patients with patent stents and grafts, and here's only a couple patients with something that's ischemic, and both of them don't have plaque ulcers, and we don't care. Isn't that interesting? So what do you think about that, Ken?
That's very interesting. Yeah, sure.
We're knocking the shoes off of everybody. Everybody's wrong, because they've done retrospective garbage studies, so they don't know nothing,
Well, I think they're looking at the wrong target.
They
essentially, from what I can see is it's the target interpretation that's wrong, and they're acting upon a target that doesn't ultimately influence the result, and they're not modifying the ones that actually can influence the result.
Yeah, okay. And we learned that basically also from our published colleagues who are looking at hypertension. And so when we do our book, we can have them write a chapter on their experience. We also are looking at cardiolipin and antiphospholipid antibodies and finding out that that's not much of a problem either. And we've had several people with that. We're also looking at the rheumatoid arthritis people, and that's not a problem either. And so we're looking at the psoriatic arthritis, and that's not a problem either. So it's really interesting where we are today. And so we'll expand our database, write an abstract, and give it to you to make the deadline, okay?
Well, what I'm already doing, Eric, is I'm writing an abstract with what I think the pertinent information is to an orthopedic audience.
Yes.
And then what I'll need is the methods with this kind of testing that's being done to be put into the abstract. I've already asked Penny and Susie to look at our individual data.
Yes.
To again show that this information has had an effect on decreasing risk and cost, and that's the point of my abstract is rather than getting too far down into the weeds about the program itself. Although they'll be in the actual presentation, this will be of great interest. But in the abstract, I think it's more important to say what the effect is.
I got it. Well, that makes a lot of sense, and we will do everything we can to support putting that together with you. Anything you need from us, you've got. And then we're going to put this other data together as well to bring into orthopedists probably in the knee and hip meeting coming up in October.
Right.
And of course, all you guys are included who have supported me. And let me tell you, there's another group you can use as a cohort, and that is we are seeing patients from you, from Vernesic, from Garlic, and from Lions. And basically, the other people have not been able to support the program because they don't have regional referrals. They have hospital referrals. And because they have such a limited community, a small village like Brandon, they get hospital referrals, and they wouldn't dare send a patient to another cardiologist under fear of certain death and under fear of the referrals going somewhere else. And so you can use those guys, Palumbo, Miranda, Infante, you can use those guys as a control group as well to see what happens to their patients over 65 or 70, right?
Yeah. Yes, that's correct. Yeah, right now we have the data on the 4 of us that have been sending our patients for this screening and trying to compare that data on how many patients have been canceled, how many patients have had a cardiac event, how many, with a rehospitalization versus the cost, versus those that have not been part of this cardiac screening either before it was started or now that it has started, so we can show that this is a cost-effective and efficacious program. That is the point of my abstract.
Yes, that sounds very good. And then anything that we write, we are going to use the Big Four orthopedists as our co-authors. The Big Four will always be on everything we write, okay?
Okay.
Yep. So that's it. I think we've done it for today. I'm sorry to drag you on for so long, but I think we had a mission and we had to bring you up to speed. And anything you need from me, we will provide. And we've got 2 very capable students here, and then we've got Rachel, who's on board when she comes. Before she even comes, she's on board. So that's very good.
So, Eric, just from a logistics standpoint, Susie and Penny have been assisting me in getting this data. Yeah. So I'm doing a preliminary abstract. I'm going to put their data into the abstract. I'll need you to review the abstract to see if it's sort of correct from the cardiac standpoint. Plus, I'll need you to do the part under the methods. Yeah. Who should Susie and Penny communicate with over the next 2 days, basically today and Monday, so I can get this abstract submitted by Monday night?
Yeah, I'll do myself. Okay.
Okay.
I'm taking it under my wing.
Okay.
Got it.
Good. We got it. We're all set.
So one quick question, Dr. Guskey. We did not include any DVTs or PEs. We just did regular cardiac events. Do you want those?
That's all we wanted. I don't want to muddy the waters by adding too many different variables. I think if cardiac is considered the #1 risk for total joints, we need to define what that risk is and how to modulate it, and eliminate the other stuff, because the DVTs is a total different scenario that will just muddy the water.
Right, I didn't include those, but I just wanted to make sure. Yeah, I've got to change my numbers a little bit. I was reading through them last night, and I didn't completely finish up I got to look up a few more patients. Unfortunately, Art gave me his flu, so I slept all night last night, so today I'm going to finish up that, and I'll resubmit some of those numbers to you by this afternoon.
So, but by the way, Ken, we are factoring in the risk for pulmonary emboli and DVT and altering the treatment for that as well when we see these patients.
Sure.
Okay. I want you to know we can't ignore that as not being cardiovascular in our evaluation of cases. We can't do that.
Okay.
Okay. Good. Rachel, Thank you for coming, Rachel. We appreciate your attending. Thank you, John, for coming. And of course, Ken, we love having you here. And so we've got everybody here. So we really appreciate you guys showing up on such little notice. Okay. I want to thank our 2 students, Rhonda and Rami, who are here. And thank you all for your support, Ken, with your staff. It's been a lovely experience for all of us.
I think this is real compelling, and getting this message out, I think, is pretty, significant. So I think as many of these orthopedic meetings that we can present this at, I think the better. As you know, the plan is to get it to AUKUS, but we want to have an abstract for the AAOS. And I wanted to put it on ISTA initially just to see what kind of questions I get, so that we have the ability to sort of hone this information and the presentation for the bigger meetings, which is AUKUS and the Academy meetings.
And actually, we have to keep in mind our goal is to change the guidelines And I probably can't do that. It's got to be the orthopedist to change these guidelines. But that should be our target ultimately. And then we're all going to co-contribute to the book.
Yep, sounds good. Okay.
Great. Super duper.
So I'll be in touch with you during the day today, probably later in the day, when I get more information from Susie and Penny, so that I can finalize my part of the abstract. Then I'll send you that, so you can do the methods part and modify mine as you suggest, and then we'll try to get everything done by Monday.
That sounds great. Of course, you'll need your overcoat and your umbrella when you go to London in that temperature.
Yeah, I understand. Been there before.
Okay, great. We'll talk later. Thanks so much.
All right, bye-bye.
Bye-bye. Bye-bye, Rachel. Bye-bye, John.
Bye.
Bye, everybody. Thanks for coming. In meeting for all. In meeting for everybody.